Long-term ventilation. We've increased in numbers of patients with complex needs living in the community, and in the Southern Trust we have currently just under 100 patients on long-term ventilation. As community physiotherapists, we are often involved in the care of these patients, but not only for their respiratory needs, we're also involved with their physical and their neurological needs as well. So we need to be confident in our ability to contribute and to help in the management of these patients in the community. So today we're going to look at and refresh on what is respiratory failure, the different types of long-term ventilation that's out there in the community, and then at the end we have some of the guidelines and references and some useful links for your own information and learning. So respiratory failure is when the lungs fail to oxygenate the arterial blood adequately and or fail to prevent the undue retention of carbon dioxide. Respiratory failure is a disease of the lungs. The respiratory system basically consists of a gas exchange organ, which is the lungs and the alveoli, and then the ventilatory pump, which is the respiratory muscles and the thorax. Either of these systems or both of these systems can fail and cause respiratory failure. Respiratory failure occurs when gas exchange in the lungs is sufficiently impaired to cause a drop in the blood levels of oxygen, and this is known as hypoxemia. And this may occur with or without an increase in the carbon dioxide levels in the arterial blood, which is known as hypercapnia. Respiratory failure is low levels of oxygen in the arterial blood. Normal or low levels of carbon dioxide in the arterial blood. So type 1 respiratory failure is essentially failed oxygenation due to the failure of gas exchange. And this quite commonly is caused by damage to the lung tissue. So for example, pneumonia, pulmonary edema or ARDS. Type 2 respiratory failure is low levels of oxygen in the arterial blood, increasing levels of carbon dioxide in the arterial blood. So type 2 respiratory failure is essentially failed ventilation, so a failure of the mechanical pump. And this can happen because of respiratory muscle weakness or fatigue in patients with chest wall deformities or neuromuscular diseases. So to treat type 1 and type 2 respiratory failure, we would normally start with oxygen. We would try to manage secretions through airway clearance techniques. So your active cycle of breathing techniques, your oscillating PEP, autogenic drainage, lung volume recruitment therapy or cough augmentation. We will also try to optimize the pharmacology to try and control airway obstruction by using bronchodilators or corticosteroids or inhaled corticosteroids. And we will also optimize our pharmacology to try and limit pulmonary edema. And we're trying to reduce the load on the respiratory muscles. But if all of the above is not effective, we may need to consider respiratory support and we may need to consider a form of ventilation. So how and when is long-term ventilation commenced? So it could be during a hospital admission for a COPD patient who has been recurrently admitted for type 2 respiratory failure, or following an admission for a traumatic event, for an example, a spinal cord injury, or following admission for a neuromuscular patient who has acute on chronic deterioration. It can also be commenced in the outpatient setting, so a patient may be referred to a respiratory consultant from a neurologist. It could be a neuromuscular patient with signs of deteriorating respiratory function, or it could be somebody who's under investigation for sleep disorders. The respiratory consultant will do an holistic assessment, and this will include spirometry because they will need to look at their tidal volumes and their vital capacities and peak flows. They will do blood gas analysis, they will look at their pulse oximetry and do overnight oximetry as well. So whenever long-term ventilation is commenced, then if we look at the prognosis, so severe conditions that are generally terminal unless they are treated by long-term ventilation, and the patients can be given supplementary oxygen. And the mechanical ventilation, don't forget, can have long-term consequences in that it can weaken respiratory muscles and they can have difficulty weaning off it. So initially they would most likely be commenced on it overnight, but you might find as the patient's condition deteriorates, the amount of hours that they are needing the long-term ventilation at home can increase. So let's just look at the type of respiratory support that's available out there. There's non-invasive techniques and invasive techniques. Non-invasive techniques would normally be used with conscious and cooperative patients. It's administered via a face mask or a nasal mask or nasal prongs. Non-invasive ventilation techniques would be known as CPAP or BiPAP, and these are pressure-controlled ventilators, where the ventilators are set to specific pressures which the machine delivers with each breath. There's also AVAPs on the community, which is average volume assured pressure support, and these ventilators are set to deliver specific tidal volumes. And the machine delivers these tidal volumes at whatever pressures are needed to reach that volume. So the pressures would be different with each breath. There are a few patients on the community who are on invasive ventilation support, and this would either be administered via an endotracheal tube or a tracheostomy. CPAP, just to refresh, is continuous positive airway pressure. Airflow is introduced into the airways to maintain a continuous pressure, to constantly splint open the airways and allow more time for gas exchange in people who are breathing spontaneously. With CPAP, the patients are required to initiate all their breaths. CPAP is a way of delivering positive end expiratory pressure, which keeps the alveoli open. It increases your functional residual capacity. It decreases atelectasis and recruits under-ventilated areas. It increases the surface area of the alveoli, which improves gas exchange. It improves your ventilation perfusion mismatching, and it improves oxygenation. And it's quite often used in type 1 respiratory failure, as just to remember, type 1 respiratory failure is failed oxygenation. And we have a nice graph here that shows that the machine delivers a continuous pressure of 5 centimetres of water, and then the patient breathes around that pressure. Bi-level positive airway pressure is similar in function and design to CPAP. It has 2 pressure settings, an inspiratory positive airway pressure, which will be known as IPAP, and an exhalation or an expiratory positive airway pressure, which is known as EPAP. This is better tolerated by the patient as it's more comfortable to breathe out as the pressure lowers on exhalation. It supports inspiratory effort and reduces the work of breathing, while also improving oxygenation. It eliminates carbon dioxide and improves tidal volume, and it's quite often used with neuromuscular disorders and respiratory disorders. As type 2 respiratory failure is a failure of the mechanical pump, this is why this would be the treatment of choice, while it also improves oxygenation as well. So looking at the graph, the 15 centimetres of water is your IPAP, your inspiratory positive airway pressure, and your 5 centimetres of water is your EPAP, which is your expiratory positive airway pressure. And the machine brings the person from the lower pressure to the higher pressure and then drops them back to the lower pressure again, and the patient breathes in between these two pressures. The difference between the two pressures is known as the pressure support. So in the Southern Trust, just to make you aware, there is no dedicated non-invasive ventilation or long-term ventilation service funded currently. We do have 2 companies in the Southern Trust who provide the ventilators, and their details are later on in the presentation. They will provide training for families and carers at the initial setup of ventilation, and these companies provide specialist support staff to provide staff for us physiotherapists within the Trust or other healthcare workers who are looking after these patients. They also provide a 24-hour helpline for the patients also. Then as physiotherapists, we are expected to respond to requests from the GP or the consultants to treat chest infections, etc. So we would be monitoring clients who are on long-term ventilation equipment, and we will link with the district nurse, for example, if there's a skin issue, maybe a breakdown on the bridge of the nose, or we would link with the company or the consultant if we found that the client wasn't tolerating the long-term ventilation, maybe throughout the night, because the pressures might need to be adjusted. So in Northern Ireland, there are currently regional meetings ongoing to try and discuss clear referral criteria for any client requiring long-term ventilation, whether it be a respiratory patient, a neuromuscular patient, or a patient who has had trauma. Also, we're trying to set up clear pathways to give clear guidance on the setup of long-term ventilation, how these patients are reviewed, and how these patients make the transition from paediatrics to the adult service. We're also trying to agree standardised documentation across the Trust and across the region, and there will likely be a contract for the equipment, and we need to ensure that the contract will include any consumables for the equipment as well. So just before we finish, it's very important that we consider the palliative care and the end-of-life issues with these patients. We need early referral and timely discussions before they reach the advanced stages of their disease, and we need to discuss with the clients and the consultants around the use of long-term ventilation or non-invasive ventilation as their disease progresses. We should encourage these discussions and encourage that they are documented using our advanced care plans we have within the Trust. And for your information, there are guidelines for the withdrawal of NIV or long-term ventilation, and there is a link on the presentation that will take you to them guidelines. In light of COVID-19, the BTS guidelines recommend that we continue with the usual method of long-term ventilation at home. However, we need to keep abreast of these guidelines in this ever-changing climate at the minute. So we have a slide now with the different guidelines that are available and that you can refer to if you need any further information. Then we also have some contact details for the 2 companies that provide the equipment within the Trust. So one company is Liquid, and this would probably have the majority of the ventilators in the Trust, and the other company is Respiratory. And then on this final page, we have useful links for the setup, guides for the setup of the ventilators and how to use the ventilators. So you can click on these links and they will take you then to these guidance. Thank you.
No, you're right.
Okay. So these are a few of the ventilators that you might come across on the community. These are the ones that are provided by Liquid. So this here is the BiPAP A40, and it's probably the most common one that you will see out there in the community. So the ventilator sits in the middle here, and at this side here, that's your battery pack, and that is detachable as well. And then at this side here, that's your humidifier. So that's where if it's recommended that it is humidified, then they fill that every day with cool boiled water, and it's replaced every day, so it is. But again, that's detachable because not every person needs it, okay? So the home circuits don't normally have any filters, but just in light of COVID-19, they are recommending that there is a filter at both ends in the hospital circuits, so there is. So that's the circuit, and then this is the most common mask that you'll find out there in the community. That's the Amara View. So it is, and then that just fits over the patient's head, and they are trained by the company how to put it on and off, and they're also trained by the company how to turn it on and off as well. If you need to entrain oxygen through it, here's your oxygen port here. So we already have the oxygen connector in place, and the oxygen is entrained in through here. So you may not have the oxygen connector in place with somebody who does not require oxygen. So that is your BiPAP 40. Then the next one that we have is the CPAP machine that will be out in the community. And just for the purposes of this, we're going to attach the same circuit in. And again, this is the ventilator, and this is the humidifier. And again, that they will be taught how to refill that humidifier by the company. And it's the same circuits that they use. And this is one of the most common masks out there in the community. They also have this mask, which will cover the nose and the mouth, and some of the patients may be on that as well. But again, the family or the carers are taught how to put them on and take them off. So that's the most common CPAP machines that you'll see out there. So in the community, you don't normally have filters because it's been provided for that particular patient, and the patients are taught how to wash out their tubing weekly and how to keep their mask clean. In the community, these masks are vented masks, so they will have, this is where the vents are in the mask, and there's no exhalation port on the system. In the hospital systems, they don't have any vents in their masks, so their masks are non-vented, but they do have an exhalation port. So a community mask does not fit with a hospital circuit, and vice versa. So if the person is going into hospital and they are bringing their ventilator with them, there's no point in them bringing their circuit. Leave their circuit at home. The hospital will provide them with a circuit, because you don't want one set of tubing and one mask to get put together, because then that could end with difficulties for the patients being able to breathe.
Okay. So this is the Trilogy 100, and this is the machine that is used in the hospital setting, and is also, we have a few patients in our community setting as well. This machine can offer full ventilation, but we use it for non-invasive ventilation within the hospital in an acutely ill patient. The main differences, as already alluded to, is the fact that the circuits have usually a full face mask with our patients, and they have they're non-vented masks because we have an exhalation port within the system. For demonstration purposes, we haven't got this at the moment, but the circuits in the hospital particularly have a hole within the tubing here that allows the CO2 to escape. The main thing is that this needs plugged in at all times, otherwise the battery can be very quickly depleted. Oxygen can be entrained at the back, and when you're looking and assessing someone on this machine, they will usually have two values of an IPAP and an EPAP and entrained oxygen. Other than that, I mean, medics will prescribe those settings. You will work with the patient while they're on the mask if it's necessary, and just relieve for expectoration. Disconnect the bottom of the mask and then encourage that to be lifted up for expectoration and returned onto the patient.